this video we are going to discuss about malaria in pregnancy and HIV in pregnancy mainly. So let us start with malaria. So if a pregnant woman have increased susceptibility to malaria, then there is an antigen called VAR2CSA antigen. Okay, pregnant women have increased susceptibility to malaria because of this antigen, that is bar C2CSA antigen, and because of this there is a formation of antibody, and this antibody accumulation of infected RBCs in placenta. Actually, this antibody formation, after this formation there is accumulation of infected RBC accumulate in placenta. So this is the problem here. So because of this, what is the problem? There are two problems. Like first one is it will lead to pregnancy specific anti-malarial immunity. Sometimes the immunity may develop against it, whereas sometimes there is increased maternal morbidity. So there is maternal mortality or morbidity mainly because of malaria infected RBC cells which are present in placenta. So this is the most common leading to malarial, because of malaria there is maternal death. The most malaria type of malaria which is leading to maternal death is Plasmodium falciparum. So falciparum type of plasmodium is the one which is leading to maternal mortality, because actually what it does is mainly it lead to kidney failure and also coma. So because of this there is more chance of maternal mortality. So what is the manifestation of malaria in the mother? In the mother there will be anemia, there's jaundice, and there's preterm labor. So these are seen in a mother with malaria. So in malaria pregnancy in the mother, you have anemia, jaundice, preterm labor. Okay, so in fetus what you see? In fetus there's increased mortality and morbidity, and there is increased chance of stillbirth, abortion, intrauterine distress, low birth weight, prematurity, congenital malarial syndrome. Of course it is less than 5% case, congenital malarial syndrome. And the test, which test you do to find whether mother or fetus has malaria? That is the thick and thin film malarial specific antigen understudy. So thick and thin film malarial specific antigen, this is what we are going to test. So in mother you will see these features: anemia, jaundice, preterm labor. In fetus you will see increased chance of stillbirth, abortions, IUD, low birth weight, prematurity. Of course congenital malarial syndrome is less than 5% in cases. So now coming to the treatment, the drug of choice is chloroquine or HCQ, hydrochloroquine. Okay, the complicated drug resistance is seen in the case of Plasmodium falciparum. So in this case we need to use a regimen called as artemisinin based regimen, regimen, which is mainly for Plasmodium falciparum. And next is chloroquine resistance Plasmodia vivax. For this we need to give mefloquine. Earlier it's contraindicated, but now it is accepted to give in pregnant females. So by this we completed malaria in pregnancy. Now let us start with HIV in pregnancy. So what to do if the mother is having HIV? Okay, so screening test which you do is opt-out method. That is, we will never force any of the patient to undergo HIV test during pregnancy. If they say they don't want to, then you can leave it. Okay, and the confirmatory test is HIV NAAT. Okay, and the most common time of transmission is few days before and at the time of labor. Okay, so what is the primary determination of transmission? That is HIV viral load. Drugs to be avoided in pregnancy due to, not actually due to teratogenicity, but due to toxicity. So the toxic drugs of HIV are no sign, which should be avoided, ritonavir, which should be avoided, and stavudine. So let me put here into mark. These all drugs should be avoided. They are toxic in HIV mother. Next, all pregnant females with HIV positive should be given ART. What is this ART? It's especially given in first trimester. Actually, this is a treatment of 3 drugs. One is tenofovir, efavirenz, and lamivudine. So these are the 3 drugs which we need to give under the ART to the female in the first trimester who is HIV positive. So from the first antenatal visit to the lifelong, we need to give all these drugs. Who is already on ART, then continue the drugs. Okay. So risk of mother to child transmission in a pregnant woman on ART. First, only 1% without breastfeeding and 2% with the breastfeeding. So you can see it's breastfeeding is not contraindicated in pregnancy because only there's a 2% chance of transmission from the mother to the child. Okay. Now coming to HIV in India. HIV in India is not an indication for cesarean section. Okay, you can do normal vaginal delivery also, and the breastfeeding is also not contraindicated, and it is not an indication of medical termination of pregnancy. Okay, so no need to do MTP in the case of HIV. But in some developed countries, if the viral load is greater than or equal to 1000 copies per milliliter, then the drug of choice, then do C-section at 38 weeks. This is actually in other countries, not in India. In India, we are giving ART, no need to do C-section. Okay. So now coming to NACO guidelines. According to NACO guidelines in India, whomever the female who is pregnant with HIV positive will do vaginal delivery. So in that vaginal delivery, we should give oxytocin for augmentation of labor so that the labor time will become short, and also we need to do early cord clamping. Okay, and we need to avoid the vaginal examinations and episiotomy. Methyl ergometrin also we need to avoid, and because methyl ergometrin will lead to vasoconstriction. So avoid per vaginal examinations, avoid episiotomy, avoid methyl ergometrin because it may lead to vasoconstriction. So what are contraindicated in pregnancy during HIV positive is artificial rupture of membrane, fetal scalp pH monitoring, instrumental delivery. All these are contraindicated because HIV may transmit in that ways. So if a patient comes in labor without knowing the HIV status, immediately do the HIV test, and if the test is positive, follow the ART. So sometimes the patient may come directly to the labor, and in the labor you may find out that HIV is positive in this female. Then just immediately start ART treatment, that is the tenofovir, efavirenz, lamivudine. Okay. So a baby born to HIV positive female, give. So to the baby now, for the baby what we need to give, because she is from the HIV positive mother, right? So you need to give nevirapine for 6 weeks, that is 2 milligrams per kg. Okay, and also case 1, let me say 2 cases. If a pregnant female already received nevirapine in the past, and the baby should be given zidovudine for 6 weeks. Why? Because already this baby will be now resistance to nevirapine, so better to give to the baby zidovudine because already mother has took it from long time. Okay, now coming to case 2, pregnant female was on ART in antenatal period for less than 4 weeks, or not on ART but HIV positive. So neonate should be given. As the mother has not took nevirapine for longer time, now we will extend the nevirapine in the fetus like neonate, that is for the 12 weeks. So before we used to give for 6 weeks in the case after delivery, but if the mother has not took nevirapine before, then in the baby we need to increase it for 12 weeks. And already in the past, if the mother is taking lot of nevirapine, because the baby may be resistant to that, so we give zidovudine for 6 weeks. So this is about the regimen which we need to follow in the adults and the neonates in case of HIV positive pregnancy. So by this we completed infections in pregnancy. Next, we'll start with abortion and MTP. Okay.